Right, let's get straight into it. Today we're doing a deep dive, an examiner-level analysis of two absolutely landmark trials that have shaped modern carotid practice, CREST and its successor, CREST-2. We're going to focus on the critical details, the design, the data, and what it all really means for us on the ground.
So, here's our game plan. We'll kick off with the core clinical question that links both of these trials. Then we'll dissect CREST, move on to CREST-2, and then really put them head-to-head in a critical appraisal. After that, we'll get into the nitty-gritty of the numbers and wrap up with the final verdict on how this all changes our day-to-day practice. Let's start with a big question.
So, what is it we're actually trying to answer here? What's the central problem that these two huge trials, separated by more than a decade, were designed to solve?
This right here is the fundamental dilemma. It's not just a simple choice between stenting and surgery anymore. The real question now is whether we should be intervening at all, especially when our medical therapy has become so incredibly effective. And it's that evolution in thinking that really connects the first CREST trial to the second.
Okay, let's wind the clock back and start with the original, foundational trial, CREST. This is the study that really set the stage for the modern debate by putting the two main revascularization techniques head-to-head.
Let's break CREST down using the PICO framework. The population, this is crucial. It was a mix of both symptomatic and asymptomatic patients. We'll come back to why that's so important later. The intervention was carotid stenting, and it was compared directly against the gold standard comparator, which was carotid endarterectomy. And the primary outcome? A composite. Periprocedural stroke, MI, or death, plus any later ipsilateral stroke. A classic, straightforward, head-to-head design.
So what was the bottom line?
Well, the headline finding was no significant difference in that composite endpoint. This basically established a state of procedural equipoise. But, the real story, the bit that matters, is in the detail. Stenting came with a higher risk of periprocedural stroke, while endarterectomy had a higher risk of MI. That specific trade-off became the absolute key take-home message from CREST.
Right. Now, fast forward a decade or so, CREST-2 comes along, and it doesn't just move the conversation forward, it completely reframes it. The question was no longer how should we intervene, it became should we intervene at all in asymptomatic patients now that medical management is so much better.
Now, the CREST-2 design, it's a bit more complex, a bit more elegant. First, the population. A massive shift. This is exclusively for patients with high-grade asymptomatic disease. And it was cleverly structured as two parallel trials. One compared stenting plus intensive medical therapy against medical therapy alone. The other compared endarterectomy plus medical therapy against medical therapy alone. So you see, the comparator is no longer another procedure. It's modern, aggressive, protocol-driven medical therapy. The outcome was a composite of stroke and death.
And this is where it gets really interesting. The results were divergent, and this is absolutely critical to grasp. The stenting arm did show a statistically significant reduction in stroke or death compared to medicine alone, but the endarterectomy arm, the benefit just didn't reach statistical significance. Understanding that split is key.
Okay, this is where you really score marks in an exam. It's about moving beyond a simple summary to a proper critical appraisal. You have to understand the methodological differences between these trials to truly understand their conclusions.
This really boils it down. CREST was a straight fight, procedure versus procedure. CREST-2 is completely different. It's a procedure versus no procedure trial. And just as important as the background, the medical therapy baseline evolved dramatically. CREST was done in an era of improving medical care, sure, but CREST-2 mandated modern intensive risk factor control with super strict targets. That alone massively dropped the baseline event rate. Now, both trials use rigorous operator credentialing, which is a huge strength for internal validity. It means the procedures were done by experts. The flip side of that, though, it limits generalizability. You can't necessarily expect these same results in a lower volume center. Another key point, CREST-2 was open label, which could introduce bias, but they did something very clever. They used an observer-blinded design for judging the outcomes, which really shores up the validity of their findings.
We also have to talk about crossover. In CREST-2, a fair few patients, about 18% who were assigned to medical therapy alone, ended up having a procedure anyway. Now that could really muddy the waters, but the investigators used an intention-to-treat analysis. What that means is they analyze everyone based on the group they were meant to be in, not the treatment they actually got. This is vital because it preserves the whole point of randomization and keeps the comparison fair.
Right, let's get into the numbers. A surface-level reading is just not going to cut it here. The real story is always in the statistical detail.
So in CREST, the big number everyone remembers is the hazard ratio for the primary endpoint, 1.11, with a confidence interval that crossed 1. Now this shows equipoise, it does not show equivalence. It's a subtle but vital distinction. The trial simply wasn't powered to prove the two procedures were the same, only that there was no significant difference. That's a classic exam trip-up.
And this is precisely why you have to unpack that composite endpoint. You can't just quote the overall hazard ratio. You must discuss the trade-off. As you see here, the stroke rate around the procedure was significantly higher with stenting, at 4.1%, but the MI rate was significantly higher with endarterectomy. That is the nuance that matters.
Now for CREST-2, the key metric is absolute risk difference, and that's because the overall event rates were so incredibly low, which is just a testament to how good modern medical therapy is. I mean, the annual ipsilateral stroke rate in the medicine-only group was tiny. When you have rates that low, even small absolute differences can become clinically meaningful, and that's exactly why the benefit from stenting tipped over into statistical significance, while the slightly smaller benefit from endarterectomy didn't quite make.
So, let's put it all together. What does this actually mean for how we manage our patients on the ward, in clinic, on a Monday morning?
The implications are huge, and they create a clear split based on symptoms. For your symptomatic patients, CREST is still very much our guide. Revascularization is the right thing to do, and we use the CREST data to choose between stenting and surgery based on anatomy, age, and comorbidities. But for asymptomatic disease, CREST-2 has changed everything. Intensive medical therapy is now a valid, evidence-based first-line strategy. Routine intervention is no longer an automatic decision.
And you can see this change reflected in the softening of all the major guideline recommendations. CREST-2 really supports a shift away from a simple algorithm based on the percentage of stenosis. The bottom line is this: the degree of stenosis, on its own, is no longer enough to justify revascularization in an asymptomatic patient. We now have to have a much more nuanced, risk-stratified, and individualized discussion with.
So here's the final verdict, which I think we can wrap up in 2 key phrases. First, CREST is practice-defining. It didn't tell us one procedure was better than the other, but it brilliantly defined the specific risks and benefits, which lets us tailor our choice of procedure to the individual patient in front of us.
And second, and this is the big one, CREST-2 is practice-changing. It fundamentally challenged a decades-old dogma of routine surgery for asymptomatic stenosis and elevated intensive medical management to a primary treatment in its own right.
So to summarize it all, the modern management of asymptomatic carotid stenosis is now a pyramid. The broad base, the foundation, the priority for every single patient is aggressive medical optimization. Intervention is now right at the very top of that pyramid, reserved only for a small, carefully selected group of patients who we think are at high risk of a future stroke, even with the best possible medical therapy.
So, in conclusion, what's the final judgment? Knowing CREST is fundamental, but a deep, critical appraisal of CREST-2 is what really separates a pass from a fail. It is without a doubt one of the most important and practice-changing carotid studies of our time. You absolutely have to know it.